Imagine Einstein, a patient who seems to cycle through doctors, aggressive outbursts, health-sabotaging behaviors, perhaps they even exercise on an injury, or present with a litany of vague somatic complaints. We often label them difficult, don't we?
Oh, absolutely. The ones you see on the schedule and you just mentally brace yourself. Like a human-shaped storm cloud walking into the clinic.
Precisely. But what if I told you that 1 in every 15 adults walking into a primary care doctor's office has borderline personality disorder?
Whoa, hold on. 1 in 15. That's 4 times higher than the general population. That's a lot of storm clouds.
Indeed. A remarkable 4-fold increase. And yet, it's chronically underdiagnosed. It's a pervasive pattern of instability in affect regulation, impulse control, interpersonal relationships, and self-image. Think of it, Einstein, like your emotional thermostat is completely broken, swinging wildly from extreme heat to extreme cold.
Okay, so it's not just being dramatic or attention-seeking. It's a genuine disorder. But what causes this emotional roller coaster?
The etiology is fascinating. It's a complex interplay of genetic predisposition, neurobiology, and, crucially, psychosocial factors. We're talking about trauma here, Einstein. Nearly a third of patients with BPD have experienced sexual assault in adulthood. Childhood trauma, neglect, it doesn't just influence you, it exacerbates a biological vulnerability.
So, it's not just a personality flaw someone needs to get over. It's deep-seated, often rooted in profound suffering. That changes everything about how we should approach these patients.
Precisely. And here's where it gets even more remarkable, a true paradigm shift. For decades, the prevailing belief was that BPD was a chronic, unchanging condition, a life sentence, if you will.
Yeah, that's what I always heard. You just learn to manage it, right?
But wait, it gets better. The latest research, studying patients over their lifespan, reveals that most patients with borderline personality disorder will actually experience remission.
No way. Remission? As in, the acute symptoms fade? The instability calms down? That's incredible. That's like finding out a chronic, incurable disease actually can be cured.
Indeed. Though, a vital caveat, global functioning, like full-time employment, may still be a struggle for many even during remission. But the core instability? That can dramatically improve.
Okay, that's a game changer. So, what's the magic bullet for this remission? Some new wonder drug, perhaps?
My dear Einstein, here is perhaps the biggest twist of all. There are no medications approved by the U.S. Food and Drug Administration specifically for the treatment of borderline personality disorder.
You're kidding me. None. For a condition that causes such profound suffering, such high suicide risk, and affects so many people.
Precisely. The evidence for pharmacologic treatments is limited, mostly for managing specific symptoms, not the core disorder. In fact, a randomized controlled trial comparing an antidepressant to psychotherapy found the medication-only group had significantly higher rates of suicide attempts.
That's astounding. So, if not drugs, what does work? What leads to this remission?
Psychotherapy, Einstein. Specifically, dialectical behavior therapy, or DBT, and mentalization-based therapy. These aren't just talk therapy. They are highly structured, intensive treatments that teach patients concrete skills to manage emotional lability, improve relationships, and reduce self-harm. DBT has been shown to dramatically reduce suicide attempts and psychiatric hospitalizations.
So, we've got this disorder that's way more common than we thought, often rooted in trauma, that was believed to be lifelong but can actually remit, and the most effective treatment isn't a pill, but intensive, skilled therapy. That completely flips the script on how we think about mental health.
You've hit the nail on the head, Einstein. It's a call to arms for better screening in primary care, for understanding the profound impact of trauma, and for investing in access to these life-changing psychotherapies. It's about moving beyond the difficult patient's label and seeing the potential for healing.
So, next time someone says, difficult patient, maybe we should ask, could this be BPD? And then, are they getting the right kind of therapy? Not just a prescription.
Precisely. A truly remarkable shift in perspective, indeed.